Antiphospholipid syndrome was previously known as APLA, antiphospholipid antibody syndrome. Genetic factors for developing primary antiphospholipid syndrome. HLA-DR4, HLA Dr. W53. Most common cause of secondary antiphospholipid syndrome. SLE. Pathophysiology of antiphospholipid syndrome. 1. Antibodies are formed against phospholipid binding proteins, which are present at surface of platelets. Leads Ag-Ab complex and activate complement. Thrombocytopenia plus thrombus occur. 2. Resistance to activated protein C. Main phospholipid binding proteins on surface of platelets. 1. Beta-2 glycoprotein. 2. Prothrombin phosphatidylserine complex. 3. Annexin 5. Resistance to activated protein C, in pathophysiology of APS. Activated protein C normally bind to phospholipid binding proteins, but due to antibodies, it can't bind and hence resistance develop. Normally activated C inhibits factors 5, 8 but due to resistance, this inhibition is decreased leading to thrombosis. The 2 hits in APS. First hit, antibody causing endothelial injury. Second hit, estrogen, smoking, obesity, prothrombotic states. Most common inherited and acquired causes for thrombophilia. Inherited, factor V Leiden mutation. Acquired, APS. Clinical features of APS. 1. Thrombosis, venous DVT greater than arterial, stroke greater than Budd-Chiari. 2. Microvascular involvement. 3. Sneddon syndrome. Microvascular involvement in APS site. Kidney and adrenals. Sneddon syndrome. Livedo reticularis, plus, HTN, plus, stroke. Classification system name for APS. Sapiro classification. Lab criteria in Sapiro classification. Any antibody positive twice over 12 weeks. 1. Anti-beta-2 glycoprotein. 2. Anti-cardiolipin antibody. 3. Lupus anticoagulant. Which antibody is most sensitive and specific in Sapiro lab criteria? Sensitive, anti-cardiolipin. Specific, lupus anticoagulant. How is lupus anticoagulant antibody detected? Indirectly by 1. Prolonged APTT. 2. High DRVVT diluted Russell Viper venom test. How is anti-beta-2 glycoprotein and anti-cardiolipin antibody detected? By ELISA. Clinical criteria in Sapiro classification. 1. In any adult any vascular event due to venous or arterial thrombosis. 2. Pregnancy criteria. What's pregnancy criteria in Sapiro classification for APS? 1 miscarriage greater than equals 10 weeks. Or, greater than equals 3 miscarriage before 10 weeks. Or, premature delivery of morphologically normal neonate due to preeclampsia, eclampsia, help. APS is the most common cause of abortions in which trimester? Second trimester. CNS manifestation of APS. Chorea, epilepsy, migraine. Cardiac manifestation of APS. Libman-Sack endocarditis, Mr. Hematological manifestation of APS. Warm antibody IHA plus, thrombocytopenia, equals Evans syndrome. Renal manifestation of APS. TMA, thrombotic microangiopathy. Endocrine manifestation of APS. Infarction of adrenals causing adrenal insufficiency, shock. Dermatological manifestation of APS. Livedo reticularis, venous obstruction plus venular dilatation. What's catastrophic APS? Greater than equals 3 organ system involvement within 1 week. Small vessels involved. Presentation, TMA of kidney or adrenal insufficiency. Management of asymptomatic patient of APS. No treatment. Management of adult patient with thrombotic event in APS. Heparin, low molecular weight heparin, warfarin, to achieve INR 2, 5 to 3. Management of catastrophic APS. Steroid, IVIG, plasmapheresis. Management of pregnancy-associated APS. Prophylactic low-dose aspirin plus heparin if 1. Pregnant with HO thrombosis. 2. KCOAPS gets pregnant. 3. HO thrombosis in previous pregnancy. Warfarin to be continued lifelong if APS diagnosed. Role of NOACS new oral anticoagulant in APS. No role.